happy to be here to talk to you today. There's no worse placement than the first paper after lunch. I hope I don't put you all to sleep.
I always think the worst placement is actually the very last workshop when half of everybody at the conference already went home.
Oh, that's another bit.
That's the other one. So take your pick.
Okay. My title is Subtle Forms of Developmental Trauma in Very Young Children, Attachment, the Unconscious, and the Traumatic Effects. For more than 40 years, I have had a love affair with babies. I guess most of us have. But I'm talking about more in a research way, trying to look at them objectively. Early when I was collecting my doctoral dissertation data, I spent hours and hours in newborn nurseries, and that was back in the 1969-70 when you could do that. You can't do that so much anymore. In fact, babies don't stay in newborn nurseries very often anymore, but at that time they did. I spent hours observing, just sitting there observing, to look for individual differences in newborns. And it was fascinating. There was one particular nurse who got pediatric nurse who was on duty there for a couple of days. And she got very used to me sitting there watching these newborn babies. And one day a little guy came in, he was just a couple of hours old, and he would wake up with a startle response like that and start to scream. There was no gradual transition from waking up, looking around, nothing. He just would startle, his whole body would get stiff like this. And the nurse came in and started to change him. And she said to me, "He's trouble." Now he's only a few hours old. She said, "Mark my words, that's a bad one." I was startled and very concerned. She said, "He's trouble." Well, this started me.
Can I ask you to put your hands down? I have to lip read you.
Oh, okay.
Thank you.
Sure. If I do it again, tell me, because I'm
so shy you noticed, right?
I'm very hand-oriented. I'm very hand-oriented.
Okay. Is anywhere but here.
Okay.
Okay.
Okay. I was so startled by her reaction that it just sent me on a whole lifetime of looking at individual differences having to do with bodies and constitution and so on. And to this day, I keep thinking about that nurse's prediction all those years ago. And what if that baby's mother reacted as the nurse did? That was my concern and question. What are the possible ongoing effects of their early interaction if the mother is already judging that the baby and she are not connecting? How do subtle forms, unconscious reactions from the primary caregiver impact the baby and the young child? How much can be accounted for by nature, and that is the constitutional differences, temperament in the infant that comes into the world, quote, different, and what is the reaction of the environment to those differences? These were some of my questions and have been for a long time. Is there a way to measure these things? The old argument of nature versus nurture is still with us, I think. I think we still think about it and worry about it. How much is nature? How much is nurture? This is the issue that really is today a totally unanswered question. Well, I personally feel that the combination of what the infant comes into the world with and the impact the infant has on the environment and the environment has on the infant is a different category, but all of this blends together to create what happens in a relationship. What about early intervention? What kind? What intervention, would intervention have changed the situation with this little guy and his people around him? What about timing of intervention? How can clinicians be alert to the subtle cues as well as to the extremes of trauma? That's very much what my paper is about today, not just the overt issues of trauma. In my experience, subtle cues can be critically important for long-term prevention. That's why I wanted to talk about it today. Any of these questions that I've raised could take up the whole hour, any one of them. But I don't want to start there. I want to start with the idea that parenthood is a developmental phase in and of itself. That it is an aspect of development that often we, myself in particular, as clinicians, sometimes forget. So I wanted to focus on that. The concept of parenthood as a developmental phase is certainly not a new idea. However, it's often overlooked and unconsciously forgotten, especially when a young couple get married, start considering being a family, and are they ready for what's ahead? I mean, that's a big question. Is this marital couple about to go from being a dyad to becoming a triad, and do they know what that is going to entail? A family triad requires a shift in both the couple, in terms of each other, and in terms of the child or children they have. How aware are the couple of their own childhood issues and or the possible unresolved multi-generational concerns from their own families of origin? Many people who come for therapy say they don't remember their childhood. If they remember anything, it's rather positive, or it's extreme negative. As was talked about yesterday morning, I was very interested in that children and adults very often, years later, remember the negative. And it struck me that a lot of people don't recall that babies shake their heads no before they shake their heads yes. In fact, there's a whole book about that called No and Yes. It's by an early analyst by the name of Renee Spitz, written in the 50s, about the head movements and the meaning, the symbolic meaning, because as most of us know, very often little children will say no when they mean yes, very early. So, negation is something that is imprinted very early. Therapy say, my parents were great. I don't know why it's so important even to talk about them. How many therapists do we have in the room? Good. Later I'm going to be presenting some clinical material, and for those of you who might not be therapists, I just want to say that what is discussed in the clinical material needs to stay in this room. It's disguised, but I would prefer that you agree to that. In an early psychoanalytic paper, Benedict, 1959, explored the topic of parenthood as a developmental phase. She, in detail, elaborates on the difference between motherhood and motherliness. Interesting terms. Of course, motherhood, as we know, what do you think of when you think of motherhood?
Somebody had a baby.
Somebody is capable of having a baby and they have a baby. That's motherhood. That can be the easiest part of parenthood. The act of motherhood has only a limited impact on the qualities associated with motherliness. Benedict points out that the psychological and often unconscious qualities of motherliness stem from the new mother's own infantile experience with her own mother, the mother who is now the grandmother and the grandfather. Sort of interesting, many years ago when I was working for the Department of Mental Health, when two young people were in big trouble, they would take the children away, and guess who they would give them to? The grandparents. The grandparents from which many of the primary issues started. Oh my gosh.
That still happens. That's not just an old time thing.
It
All the
isn't?
time.
It's still going on?
Oh, yeah.
Well, I guess they need to think analytically a little bit more about the unconscious. Okay. It's important to keep in mind that a newborn's need for mothering is absolute. Absolute. The baby needs the mother 100%. The baby is totally dependent on being cared for. This is the nature of survival of our species. Not so for the new mother of that infant. The mother's attitude and behavior is variable, sometimes highly ambivalent and complex. Mother is not only a giver, she is a receiver. And if she doesn't receive something that connects to her own inside feelings, she may be easily personally hurt. Benedict goes on to talk about how later giving and receiving becomes, in a person's personality, what we think of as reciprocity. So it's very, very critical and important that early interactive quality that goes on between the mother and the newborn becomes what we call introjected in a way that has positive feelings for the infant. Reciprocity is a very meaningful quality in mature people. The newborn infant is slow to perceive the mother as outside him or herself. It is through the process of repetitions during feedings, tactile touching, seeing, and hearing that such patterns result in learning traces laid down in the developing baby's mind. Only later is this considered real learning as we as adults think of it, because in the beginning it's sensory-based. It's sensory and kinesthetic. Cognition, or recall of knowing, is what the mother object is and is not for the baby. So the baby is very, very slowly beginning to differentiate what's me and what's not me. Through this emotionally charged repetitive process, what analysts call introjection. Now that's a word that's used a lot, and a lot of people struggle with it. What does introjection mean? It means that quality that the baby takes in over time, where it can be parts of a mother or parts of a father, but it creates an image in the baby's mind of what a mother is and what a father is. And that is what the baby emotionally reacts to, not necessarily the mother that you know as a friend or as a relative or whatever the adult connection is. The baby's reaction is not going to be identical with anybody else's. Benedict calls this the emotional symbiosis on the part of the newborn, the young child, and then the adult. Here's her definition. It is a reciprocal interaction between mother and child, which through the process of introjection, what I've just defined for you, and identification, which is another concept, creates a structural change in each of the participants. So she's saying while the baby's changing, the mother is also changing. And that's the piece that is the developmental piece for the new parents. Each single and interrelated action and interaction leads to identifications, not only of the internalized object, but also a mirror image of the mother's attitude about things. So the baby is not only taking in what happens between the baby and the mother, but also what the mother is saying or feeling or doing in the environment. So it is a huge absorption. I think of the baby as a sponge. It's just taking it all in. Not necessarily in a whole way. Either low self-esteem or high self-esteem. Some of it comes from this early reciprocity. Herein lies the roots for the baby of confidence, or the opposite. The lack thereof can also be very damaging in the growing child. It's important to remember that when the infant introjects, it may not represent the real mother, as I was just saying. That is the actual mother. It may be only part of the mother that is introjected. It is the baby's experience that we're talking about. This is the baby's experience of motherliness, not motherhood. The baby's image of the mother resides in the baby's mind, either as a whole piece or as a partial piece. While it may not change during development, memory traces remain in the baby's body. I call this muscle memory. It is mostly repressed by us adults, but it's there all the time in our bodies. D.W. Winnicott, a British analyst, writes about good enough mothering. I'm sure many of you have heard about good enough mothering. Or he says there is no such thing as a baby without a mother. Now he means this metaphorically, but given that the baby can't survive without a significant other, that's what he means. He emphasizes that this is an asymmetrical dyad. What the mother gives is different than what the baby gives. While the infant is interjecting parts of mother, the mother is also changing and achieving a new integration to her own personality. If she is highly conflicted about herself in this, quote, new role of motherhood, she may experience her own difficulties at this very vulnerable time in her life. When she can't adapt, when necessary internal shifts do not occur for her, she might experience what is considered an enormous loss that she may or may not be conscious of after birth. Such sensations of, I am no longer full, a new mother told me. I feel empty inside. Feelings of bodily and psychic loss can lead to debilitating depression. And as she is then suffering from her own separation trauma, it has to be thought about that way. It's not just depression, it's also separation. In my practice, I have heard fantasies of women with postpartum depression which reveal things like, I wish I could put the baby back inside. Baby wouldn't cry so much. The baby wouldn't demand so much. One woman reported fearful dreams of eating up the baby. Such terror fantasies require intervention and ongoing treatment for the mother's well-being and that of her infant, as her own sense of being good enough has not very much strength at that point. On the other side of the dyad, the baby who is hard to soothe or who has colic or will not latch onto the breast Or the baby described earlier in this paper, who wakes up with instant bodily startle with shrieking sounds. Such a baby can evoke enormous anxiety, rage, as well as feelings of helplessness on the part of both parents. In extreme cases, aggression toward the infant can be acted out with tragic results. We read about such things all the time in the daily newspaper, hear it on the television. A parent's ability to contain such aggressive feelings without acting on them is a significant issue throughout life, but most especially during the certain vulnerable times when one is learning to cope, to adapt to a new baby. It is far more complex than simply mind over matter. You can't say to a new mother or father, just change the what you're doing. Doesn't work. Doesn't work. Such feelings simply cannot be willed away. Aggression and its adaptive containment stems from each person's own early experiences. We learn to adapt before we're 5 years old. And we're now asking somebody who is maybe 20 years older than that to adapt when they haven't really learned themselves how to adapt to their own aggression. So you have this multi-generational issue being carried on. Even brief exposure to aggressive acts can have a profound impact during the early vulnerable years. What has been introjected by the highly observant growing child comes not only from parents, but it also comes from other children. It comes from television and other external stimuli in the environment. Ambient behaviors on the child's part often surprise the parents, and they cause them great worry and concern. Now I just want to give you a brief vignette. You can continue for this one.
Okay.
It's the longer one that I don't want recorded.
Okay, yes, let me know.
Okay. Okay, this one represents a young child's, quote, identification with the aggressor. Do you all understand that term? Everybody knows it? Good. If you don't, I'll explain it.
Can you explain it?
Yeah. At a very young age, somewhere between 3.5, 4.5, somewhere like that. I'm going to just talk about little boys, but it also happens with little girls. They begin to assert themselves. There is no way for a 3-year-old to know how to modify their behavior. So you see an extreme of wanting to be the boss, wanting to be the king of the hill, wanting to be the leader, wanting to do all kinds of powerful things. Now, this is an analytic term, but it really means that inside the child is testing out, who's going to stop me? How powerful can I be? So this is where, when moms and dads don't set limits in little kids before the age of 3 or 4, there's going to be big trouble, because the child is going to think they can do whatever they want. They can run over the parents because nobody has stopped them before. Why are they going to stop them now? Now that's just a very superficial way of describing identification with the aggressor, because it's internalized and the child begins to feel very powerful or identified with somebody that they see aggressing. It may be another child, it may be the dad yelling at them, or the mom yelling at them. There are all kinds of pieces of what is considered punitive behavior that might be internalized by the child. This is a normal stage of development. When you see it again, you might see it on the 14 or 15-year-old who dad says, no, you can't have the car keys at 16, and the kid says, well, I'm going to take the car anyway. That would be a good example of this child has internalized identification with the aggressor, and it's still there. And the dad is not going to stop him at that point. Very difficult. Okay, I want to tell you about Josh. Josh's parents were warm, watchful, and tender, and he had a very attentive mother. Josh was a wanted child to a bright, successful couple in their mid-30s. The new mom did not work for months after his birth, devoting herself full-time to Josh's care. She was well aware of attachment issues. She began working again only part-time and at home when Josh was 10 months old and doing well. She felt their attachment was strong. She was nursing well. Josh was thriving and she was ready to do her work. She continued to nurse successfully until Josh was around 15 months of age. Her career job prior to pregnancy was to watch and evaluate TV series for one of the networks. Many of the programs had highly violent content. It was her job to sort out those that were too violent for TV. It was an easy job, she said, and she was happy to return to it at home after the birth of Josh. Daily, Josh was in the room with her, often sitting on her lap or nursing, sometimes sleeping or playing nearby while she watched TV and wrote up her impressions. Sounds simple. Mother described this as an ideal arrangement for her. After a few weeks of working at home, Josh began to wake up multiple times during the night, screaming and inconsolable. During the day, he started to bite and kick her, Mom, for no identifiable reason. Both parents were baffled about this behavior. They said, "We're trying so hard to be good parents." They felt helpless as the behaviors were accelerating. They feared he was becoming a, quote, unpredictable monster. It was just about a year old. They sought consultation because they felt helpless and at the end of their parental rope. As they described their son to me, at first I was baffled. I could not figure out what was going on. All developmental landmarks were in place. His first year thus far had been uneventful for trauma, any overt trauma. On more careful discussions, we focused on his current day activities. When the watching of violent TV was revealed, Mother said he did not even seem to, quote, pay attention. But he was, big time. He heard the noise. He heard the violent sounds coming from the TV on a daily basis. Most likely, he was even looking at the TV, glancing up. She didn't think he was looking. He saw the angry expressions on the adults' faces, fist fighting. He heard gunshots, and so on. Once this was brought to Mother and Father's attention, Mom was shocked. She said she had no idea. This had never occurred to her, that this would be a problem, quote, a problem. Josh's capacity and an awareness of the environment was totally a surprise to her in this area. She wanted it very badly. She wanted to be doing her work. But she immediately changed her schedule. She contained her work time to only periods when he was napping and at night after he was asleep. How long do you think it took for the behaviors to change? Anybody want to take a guess?
A long time.
1 month. 1 month, and his aggressive behaviors subsided. Once again, he was sleeping through the night. No more nightmares. I mean, are there nightmares in 10-month-olds? I don't know. But whatever was waking him up from a dead sleep stopped. He was once again they're, quote, not a little monster. Later, Mom told me she had no idea a child of that age would be so aware. Consciously, she said she thought she was being a good mom by keeping him close while she worked. So here you see the mom's conflict. And it's, you know, it's so understandable. It's so reasonable. Okay, now I kind of want to switch to another area which has to do with assessment and intervention. Working with parents at the beginning of treatment is a challenge for any clinician. If only all interventions can work out as well as this one did, I would be very happy. Over the years, I found it enormously helpful to use an observational assessment with both mother and child together in my office during the initial stages of treatment. In 2001, I taught a course for clinicians on different methods of infant assessment. I found material on a unique method by Elizabeth Muir and her colleagues in Canada at the Hicks Delcrest Center. If anybody here know that center? Their work was highly compatible to my psychoanalytic thinking, while their method of intervention was totally new to me. Their theories are drawn from Winnicott's work on the holding environment and the importance of a relational dyadic play space, as well as Melanie Klein's ideas about projection and projective identification. Their theory, like Benedict, is grounded on the premise that there is an unconscious repetition pattern being enacted and reenacted between mother and infant whose roots are multi-generational, and that is, they come from unresolved conflicts of the parents and they're being repeated in the present with their child. Muir researched the literature on infant intervention and did not find any method that utilized the activity of the infant in the presence of the mother that specifically addressed interrelational issues in the dyad and in the development of the self of the infant at the same time. This method is called the watch, wait, and wonder method. I'm going to describe it to you. Does anybody know it? Do you? Great. Great. You like it? The method is deceptively simple, yet it is not simple. It's not simple for the mother, and it's not simple for the therapist to maintain. The central idea is that the infant is the initiator of any interaction. Just think about that for a minute. I'm talking about 3 and 4 month old babies. There is a play space. The mother becomes the observer, and she becomes the observer of her own infant. In other words, she is to watch, wait, and wonder, and so is the therapist. It is important to note that there is a parallel process of observation. While mother is observing the baby and not interacting with her baby, the therapist is observing the dyad and each segment of the dyad. In this way, the therapist's skill is also tested, in that she must be able to stay within the dynamic process while using her own observing ego as a psychoanalyst or as a psychotherapist of any kind for formulating later interventions. The 2-part session of 50 minutes each is divided into 30 minutes or less of observation of baby by mother and therapist with no talking or interaction unless the baby becomes overly stressed. If that happens, you break it and mother tends to baby. The second part of the session is 20 minutes, and this is designated as feedback time. This is for mother to give her observations of what she's seen in her infant. Her thoughts about how she felt as she watched this, and her associations of past memories and experiences, even from her own childhood, if they come up. During the feedback time, the therapist does not take over from the mother, nor expand on any of her observations. In the beginning, the mother's remarks may be sparse, and the therapist must refrain from preempting the mother's own discoveries about her own infant. And let me tell you, that's tough. Any therapist in this room will tell you it is tough, because the therapist has to contain what she may be thinking about what's going on in this dyad. This can be a highly sensitive time where mother begins to discover her capacities, discover the capacities in her infant that she's not been aware of. It's a key aspect of beginning separation and growing individuality for the infant. In other words, the watch, wait, and wonder method is built on the model of the infant as an initiator and mother as discoverer of her child's uniqueness. Her subjective perceptions and or expectations will slowly lessen as she becomes more comfortable with her own observations within the setting. Thus, she will become a more accurate observer herself of her child.
Could you repeat that sentence? That's
What part?
lovely.
Her subjective perceptions and or expectations, that's a good word, will slowly lessen as she becomes more comfortable. However, if mother is puzzled or becomes concerned about the things that she's seeing that are difficult for her to tolerate, then the therapist has an opportunity to gently discuss these things and these experiences, at first in a very limited way, with deeper discussion after the therapist and the mother have a closer relationship. Now, Muir et al., Muir is the originator of this, has certain contraindications for treatment. And one of them that is very important is if the mother is severely depressed. It's not a good idea to use the method. If mother is too needy herself, if the parents happen to be in mourning over the death of somebody in the family. She says if infants are only 4 months of age, she felt that that was too young developmentally to use this method. However, the case I'm going to describe to you is with a little boy who was only 3 months, so I challenge that 4 months is the cutoff. The process of the sessions are 8 to 20 weeks duration. The couple of the mother child that I'm going to talk about, I saw for 4.5 months, so I also disagree with that. It also depends on how much the mother wants to continue. Initial weeks involve the infant seeing and securing the mother as what they call safe base. The infant begins to use the mother as an object. The infant more freely explores and manipulates toys in the play space beyond the mother's orbit. And that takes a while. In my experience, it takes a while before a child under 6 months really is interested in the toys in the play space. In 2002, the Los Angeles Institute for Psychoanalytic Studies started a new trauma program for early intervention in the community. It was called Infants and Parents Developing Together. And guess who we collaborated with? Ruth. We worked at the church in Echo Park. I wanted to work with a mother and a baby. A lot of my colleagues were working with individuals, adult individuals. I had just read about the Watch, Wait, and Wonder method, and I wanted to work with a dyad and see how it felt, what the experience would be like. Okay, now I need you to cut that off because I'm going to give case material.